Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine cook-Garard from the nursing department here at Nassau Community College, along with my co-host, nursing student Virginia Gavin. And today we're talking about emergency room traumas, the surgeries that can help, and how it compares to what you see in the medical drama on TV. Our guest today is Dr. Gerard Baltazar, a trauma and acute care surgeon at NYU Winthrop Hospital in Mineola, and an assistant professor of NYU Medical School. Before joining Winthrop team, most of Dr. Baltazar's surgery work has been in the underserved communities of East New York, Newark, and the Bronx, as well as mission work in Haiti, the Philippines, and South America. Dr. Baltazar, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. Welcome.
Yeah, thank you so very much. It's great to be here.
So you have a very interesting career, and tell us first about yourself and what made you choose such an important work.
Well, I've always been interested in helping people when they're at their worst. In my own childhood, I had some challenges in my process of growing up, and that encouraged me to go out there and find a profession that I could be there when people are having their worst day. Mm-hmm. Trauma, acute care surgery, those patients that come in through the emergency room and need an operation as an emergency are usually the patients who are some of the sickest and also in the most need, and I like to be there for them.
So tell us a little bit about your personal story. What brought you to medicine? What makes you choose a career? It's such a wonderful career.
Yeah, well, my mother was a doctor, but in the real personal story is that I grew up in a household that was full of a lot of domestic violence and issues that were very challenging, especially for a young person growing up, and that built a lot of strength in my character and a lot of resilience in my ability to handle difficult situations like child abuse and domestic violence, and that, as my years went on, matured into following in my mother's own footsteps into medicine, but picking a different specialty than she did. She was an OBGYN, but I went into a field that really kind of harkens to my character growing up. And surgery,
and your personal story.
Yeah, and surgery was part of that, but then trauma surgery, even with the unique challenges that trauma surgeons often face, things like getting underpaid in many communities, also not having the same kind of respect that you might expect from maybe a much more fine subspecialty like neurosurgery, for example. And also the fact that you have to deal with patients who are more challenging in many ways and may not need as many operations. I still felt drawn to the field because deep in my heart, I really want to help people who need it the most.
It's inspiring. So tell me, when you were talking about trauma surgery, what may that include? What does that look like?
Well, trauma surgery involves any kind of operations or care for patients who have a lot of major injuries. Things like motor vehicle crashes, gunshot wounds, stab wounds, falls from height, people getting hit by cars, even just old people falling down and breaking some bones and damaging their brains. Those are part of what trauma surgeons tend to deal with.
And with this type of trauma surgery, are you meeting the patients in the ER, or you just stay in the operating room and they are just brought to you specifically for that specialty? How does that work?
All trauma centers, like NYU Winthrop, they have a separate trauma bay where the trauma patients get filtered into after they've been deemed by the EMTs, the ambulance workers, that they need the trauma center, or if they just arrive and have been deemed by the hospital to need the trauma center. What's unique about NYU Winthrop is that we have our own independent freestanding trauma center with our own set of computers, our own set of areas to care for patients, so that we can take as many trauma victims as we need to into this area and have a complete set of tools. We can even operate there if we need to in order to stabilize the patients who are majorly injured.
How does trauma surgery different than a usual or regular surgery, if you will?
Trauma surgery involves a lot of improvisation. You do not know exactly what's going to be injured in a patient when they come in with whatever they come in with in terms of injuries. If, for example, a gunshot wound is entering one place, it could exit a whole different place, and anything in between could be injured. So unlike the other subspecialists who maybe can plan their operation weeks in advance, have everything mapped out, and they're ready to go, and with all the different equipment that they need, when someone comes in and they're unstable and they need an operation right away from an injury, that process of getting to the operating room, it involves discovery of what the injury is and making a plan on the fly. And that's a lot of what makes trauma surgeons very special.
Can you tell us what some of the more common operations that you perform?
It depends on the area that you're working. If you're working in an area that has a whole bunch of penetrating trauma, like stab wounds or gunshot wounds, then you're dealing a lot more often with holes in intestines, holes in the liver, and one of my favorite operations to do is to repair a hole in the heart. And you do see that quite a bit. People do love to stab other people in the heart.
Wow. So what happens when you have gunshot wounds, for example? How is that handled different than the stab wound? With a gunshot wound, does the bullet removed often by you? And then I guess the bleeding has to be stopped with what is the procedure? Tell us some of it. Give us a little picturamic.
Well, that is one thing that I really want the community to understand. Yeah. Gunshot wounds compared to stab wounds are much more deadly, period. There's not really a comparison. A stab wound has a finite distance it can travel, and unlike a bullet, the stab wound doesn't have this shockwave force around it. If you ever seen The Matrix, the movie, when the bullet is flying through the air, they show this little shockwave around it. That actually exists. If you ever go onto YouTube, you can watch these gel studies where they shoot bullets through gels, and the destruction that occurs around this tiny little bullet is quite dramatic. So even if the bullet makes a single tract one direction, in and out, fine. The actual area around where that bullet went, all those organs can be destroyed at once. So the goal then is to get the patient stabilized as soon as you can, get them to the operating room, and just really improvise to try to figure out what is the next step to try to stabilize them the fastest.
Do you remove the bullet?
The removal of the bullet is always depicted on television as the way to save somebody. That is the farthest thing from the truth. No, that never happens. We don't go after bullets unless we absolutely have to because it's right there usually. Not because the bullet that's laying there is going to do any kind of damage in the future. A lot of people ask, are you going to have lead poisoning in the future? No, that's not a thing. Not a thing.
Right.
What they do on television is they always have that pause of 30 seconds as everyone in the room goes silent, and then slowly the surgeon reaches in and they pull the bullet up, they hold it up in the air, everyone looks at it, everyone applauds, and all of a sudden this beeping on the monitor, the heartbeat comes back. That never happens.
Never happens.
Never.
So you really want to stabilize stop the hemorrhaging.
Absolutely. The first step is stabilizing and stopping the hemorrhage, making sure that the blood is going in. If you can't stop it right away without getting to the operating room, make sure you have enough access to the venous system, to the veins, so that you can keep giving enough blood as the patient's losing
And you're giving blood and giving fluids to the patient.
Absolutely.
So who's in the operating room? What does it look like in the operating room? It's you and whom else?
It's me, the residents, if we're in a training program, maybe some physician assistants, the technicians who are helping supply the instruments, the anesthesiologist, and oftentimes it is a rescue operation where the patient is highly unstable. We have extra assistants running back and forth to get blood and to get any other equipment we may need to try to stabilize the patient.
So you work mostly in the underserved communities. So when do you see most of the gunshots and these traumas? Is it mostly on the weekends or during the week? Do you find that there is more of a tendency to see a lot of your traumas on the weekend?
Yes.
I don't know.
Yes, I do see that trend.
Okay.
There's been some studies looking at those kind of trends, and seasonally or time of day. And we'll see more events usually on the weekends, in the evenings, when people go out and they're around each other and they're probably imbibing some things they shouldn't be imbibing. And sure enough, that will be a recipe for people not being very happy with each other and maybe getting into fights.
Yeah. So what makes it's very interesting that most of your work, or much of your work has been in the underserved communities. What makes working in the underserved communities different than working in a more affluent community?
Underserved communities tend to have the issues that you'd expect to find in lower socioeconomic status communities.
Okay.
Meaning there's overcrowding, there are more folks who are immigrants, lower educational levels, and also the fact that there's increased poverty means there's more need and more, in some cases, desperation, therefore often more crime. So you do tend to see more of the violent trauma in those communities. In affluent communities, there is a more tendency to see bad blunt trauma as opposed to penetrating trauma. Blunt trauma meaning high-speed crashes, people getting hit by cars, maybe even more people falling down and having various major but not life-threatening injuries compared to the violent trauma that we often see in underserved communities.
So tell us, I noticed that you are a DO. How does the role of a DO differ from an MD?
The role doesn't really differ that much, but the training is different. A DO being a doctor of osteopathic medicine as opposed to an MD or a medical doctor. Both the MD and the DO have full practice rights throughout the United States and in several other countries as well. The difference in training is that the DOs get trained also in more holistic care, more of a philosophy and a actual practice of treating the patient as a whole. The most remarkable thing about DOs is our ability to diagnose and treat with our hands using something called osteopathic manipulative treatment.
Mm-hmm. And so the way you treat trauma may look different than with a MD.
Down the line, I would say so. If someone is very unstable, the trauma care for that
protocols are the same.
Yes, they'll be about the same. But in patients who are a little bit more stable, there are ways to treat patients who are, say, in pain or who have difficulty breathing that you can do just using your hands. For example, I had a patient who just an older lady fell down, broke her leg. She started having a bad spasm in her leg right in front of us as we were doing our rounds. We asked the nursing staff to go get the medication. They said, we got to get it from pharmacy. So I just got down on my knees and started doing a little manipulation on her to try and calm down the spasm. That talent only comes if you have the DO training. Mm-hmm. And within 2 minutes, she was no longer screaming in pain. She was falling asleep and saying, thank you, while the nurse was coming in, reporting again, we still need to get the medication.
Interesting.
So without breaking any HIPAA laws, do any particular patients stand out to you that you've treated?
Yeah, there are a couple patients that stand out to me, both of whom I've discussed publicly before. So it's not
okay.
And one of them, both of them, the theme is the same. I had a patient that I treated from a gunshot wound while I was volunteering in Haiti, and a patient who I recently treated with a gunshot wound in the Bronx. Both of those patients stood out to me because of the severity of the injuries, because of the uniqueness of the circumstances in which they got injured, and their remarkable recoveries. But what really, really stood out was the type of people that they are. Mm-hmm. They're good people. They're kind people. They have a lot of capacity for forgiveness in a way that I don't think I have. And to give those folks a chance to live and then do good on the other end of things, that is what I think we are all trying to do in trauma surgery in our hearts. Mm-hmm. We're trying to create life or allow life to happen so that life can then do good down the line. Now, a lot of people would say, why are you treating these gunshot wound victims? Why are you treating people who get hurt? They were just doing something stupid, or they deserve it. And actually, when I started to publish work about this one gunshot wound victim in the Bronx, the responses from in the comments section on social media and other areas was, this person's a gangbanger, this person is an inner city person who cares.
They're judgmental.
Mm-hmm. But when you're doing trauma surgery, you have to go into that trauma bay with an open heart to be willing to do so much work, improvise, put yourself at risk, and know that not only is this person going to need all this help right now, but probably for weeks of critical care, of intensive care, which is also something trauma surgeons do, is the intensive care end of things. And you have to invest a lot of yourself and trust that even if this person is on paper someone that should not be trusted, that they have the capacity for good.
Awesome. Let's take a quick break. My name is Dr. Jeanine cook-Garard from the nursing department here at Nassau Community College, along with my student co-host, Virginia Gavin. And today we're talking with Dr. Gerard Baltazar, who is a trauma and acute surgeon at NYU Winthrop Hospital in Mineola. And we're talking about emergency room traumas and the surgery involved. You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.
Adopt US Kids presents What to Expect When You're Expecting. A teenager. Learning the lingo.
Today I'm going to help parents translate teen slang. Now, when a teen says something is on fleek, it's exactly like saying, that's rad. It simply means that something is awesome or cool. Another one is totes. It's exactly like saying, totally, just shorter. As in, I totes love going to the mall with Becca. Another word you might hear is jelly. Jelly is a shorter, better way to say jealous. As in, Chloe, I am like so jelly of your unicorn phone case.
You don't have to speak teen to be a perfect parent. Thousands of teens in foster care will think you're, rad, just the same. To learn more, visit adoptuskids.org. A public service announcement brought to you by the U.S. Department of Health and Human Services, Adopt U.S. Kids, and the Ad Council.
We now return to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.
And thanks for being with us today. This is Dr. Jeanine cook-Garard from the nursing department here at Nassau Community College, along with my student co-host, Virginia Gavin. And today we're talking with Dr. Gerard Baltazar, who is a trauma and acute care surgeon at NYU Winthrop Hospital in Mineola. And we're talking about emergency room traumas and the surgeries involved.
So, Dr. Baltazar, can you tell us about a program you offer called Stop the Bleed?
Yeah, that's a great program. All trauma centers have to have some outreach into the community. It's part of our mission. And at NYU Winthrop, one of the missions that we have is to help the community understand how to prevent major hemorrhage when it happens right in front of you. And that's what Stop the Bleed does. Stop the Bleed is a program that's put on nationally by the American College of Surgeons Committee on Trauma. What it does is teaches anyone, from the layperson to the medical professional, how to understand what is major hemorrhage and how to do the initial management to slow it down so that there is time for EMS to arrive and for definitive care to happen.
So can you give us a little bit of that you would suggest if there is a bleed?
You'll start to see these kits popping up next to where they have the CPR kits. And in those kits, there are gloves so you can put pressure on a wound. There is gauze to pack a wound that might be deep and to allow that pressure that you put on it then to be transmitted to the blood vessel that's bleeding deep inside. Also, these kits that you'll find, there will be tourniquets. True tourniquets, not improvised tourniquets, and you can put that tourniquet on above a bleeding area so that you can then cut off the blood supply to that area that's bleeding. And this whole idea was born out of, unfortunately or fortunately, out of the increasing number of mass casualty incidents, mass shootings that we've been seeing in our country. The idea is that if we have more of these people out there able to slow down the bleeding or stop the bleeding in some of these instances, or just because somebody cut themselves in the kitchen with a knife, those people will then be out there saving more lives or helping us save more lives.
So like a defibrillator that is portable a lot in the public areas, are these trauma, I guess, stop the bleed cases where you have the tourniquets and the gauze and all, is this going to be available in public places?
More and more. That is part of the push.
Okay.
And in fact,
I can even see it in the home setting.
Absolutely. In your car. You never know. And we're finding as the studies are starting to come out that there are instances in Las Vegas and other places where there have been mass casualty incidents, mass shootings, and people have said, I had this training, I had a tourniquet in my backpack. That's why this person got to keep their leg and their life.
So there is a training associated with this. This is just not a box that has equipment. There is a training. Is there a certification that accompanies the training?
Yes, it's a short course, and if you want to take the course, call NYU Winthrop Trauma Center, and we will come out and we will teach your organization, your student group, whatever it is. NYU Winthrop Trauma Team would be glad to teach them.
And what is the website again? It's NYU Trauma Center. Can I Google that? Is it Googleable?
You can definitely Google that, and you can find us on the NYU Winthrop Hospital main website. Just look for the Trauma Center.
And who comes to teach these courses? Would it be you? Would it be an RN? Who comes to actually do the teaching?
We have an RN who is managing the outreach programs. She would be there. I could be there, one of the doctors. We have physician assistants who would be sometimes helping out as well. It's a team effort because we're trying to get this out to as many people as we possibly can to reach that critical number where we can make a real effect in the community.
So outside of your surgery for traumas, what else are you involved in the community? Do you do anything else in the community?
I have been involved in violence prevention programs, and we're all involved in research. I think the research I'm most interested in at the moment is violence prevention, but also I'm interested in trying to accelerate the access to trauma centers. One group I've been working with, and this is probably something cool that some of the people in your listening audience might actually have on their phone, is the Citizen app. I've been working with the Citizen app group. The Citizen app, it's a way that they are filtering 911 calls when they're public into an app so that you can find out what's happening around you. Is there a gunshot wound down the street? Is there a bad crash where people are injured on the highway so that you can figure out how you're going to plan your day and where to avoid things. And there may be other applications for it too. One of the applications we're studying right now is whether or not a notification from the Citizen app would give us some pre-notification of an imminent trauma arriving, whereas otherwise we would have to wait for EMS to get to the scene, assess the scene, and then decide, okay, this needs to come to NYU Winthrop's Trauma Center, let's call them. That, in some cases, especially when a patient is in extremis or near the end of life, we have minutes or seconds that count, and those minutes and seconds that might come sooner to us, the information might come sooner to us to give us those minutes and seconds through something like the Citizen app would improve our ability to care for patients, potentially.
So do you notice that in the underserved communities where there is a trauma, that the first responders are key to that individual surviving the trauma? Is it the first survivors that are key, or is it the surgeons who are intervening that is key for that person surviving the trauma?
It takes a village. Yeah. It absolutely takes a village. Yeah. We have to all use our skill set to help patients who desperately need help to get the help. What we find is that EMS, the sooner they get the patients into the ambulance and to the hospital, even if the patients remain somewhat unstable on the way to the hospital, that's the best place for them to be, is at the hospital with all the resources there. There have been study after study showing that, especially in trauma, if you take the patient who is unstable right away, they will do better.
So I noticed that a lot of your work is in Haiti, in the Philippines, and in other countries. How do the hospitals look, and how do they address trauma? I know that here we pretty much have everything state-of-the-art at your fingertips. What does that mean, and how challenging is it for you to go to another country now and being able to deal or address the trauma?
Well, in the United States, state-of-the-art is definitely in certain places. NYU Winthrop has everything state-of-the-art. It's wonderful there. Yeah. But certainly in the inner cities, in New York City, even just a few miles from here, the state-of-the-art is not necessarily the standard.
Really? Okay.
What going to a developing country does for me is reinvigorate. There's a lot of less red tape to performing good medical care out there, and there's also a lot of ways that you can become more improvisational and really learn the basics of how to treat someone surgically without all the bells and the whistles. And that also is very fulfilling to go there, because what you should do when you go on these missions is not only help people, not only do the medical stuff, but to leave behind some training so that we can up the skill set and the surgical capacity of the hospitals in those areas.
So you have noticed, in just getting back to what your point was, you said that even here in the United States, there are differences in the inner city hospitals versus the ones that are here on Long Island. So are you seeing health disparities and differences as it relates to how you can care for someone with a trauma if you were to go to Bronx versus going to Mineola? And, tell me about that disparity that you see.
Yes, and it's unfortunate there is that disparity. In America, we have so much extra money that we should be really trying to spread it around and help other people who need it more than we may need it. Yeah. The technology at NYU Winthrop, for example, is quite advanced. We have everything from what's called ECMO, which is basically a heart-lung machine externally, to CVVH machines where it's an external kidney. We have all kinds of medications and technologies to check if you're bleeding out of control and medications to reverse that bleeding out of control. Those kind of technologies are not at many hospitals, and they're not in the hospitals probably that have more severe trauma, more violent trauma that probably need this more.
How about access to blood products? Like, I know during your trauma surgeries, you probably need blood. Is that something that you can readily get when you're traveling to around the globe, to Haiti, to Philippines, and all these areas? What is the difference in the United States in getting blood products?
There's a great blood access system here in the United States. More people need to donate, and I encourage you all out there listening to please donate blood on a regular basis, because we're always in need in this country. The access to blood products can sometimes be limited depending on your hospital as well. For example, where I previously worked, we would only have one bag of platelets available, period. And if we need another one, no matter what's happened to the patient, we have to call the main blood bank and get another one from the central supply area in the city. Whereas here, it's much easier to get blood products. They come right away, they're the right amount, and over they'll come if we need it. There's less lag, and there's a lot more efficiency. And that just comes with having more resources to make those things happen.
Yeah.
I'll tell you one quick story about Haiti. When I was taking care of one of my patients there who was shot, he needed blood products over and over again. His blood pressure would go up and go back down, go up and go back down as we were able to get blood products. But at the time, there was no steady supply of blood products. You had to, in order to get a bag of blood, you had to send somebody over to put their arm out, and once the needle was in their arm and they were donating a unit of blood, then they would hand you the unit of blood they already had on file in the fridge, and then you could take that back and transfuse your patient. So when we had this patient who was dying, we would send people in fleets to bring back one bag of blood at a time, as they were able to donate another one.
Wow, that's something.
We're very lucky in this country.
Yeah, I'm hearing that. So I really have to thank you for what you do. It is an art and a science, what you're doing, surgery to these patients who are traumatized. How can we get in contact with you? Because I'm very interested in Stop the Bleed, this program that you are involved with. How can people contact you?
Probably the easiest way to contact us is to go to the NYU Winthrop Hospital website and find the link to the trauma center. It's very easy. The website is very accessible, and we will be glad to help you out.
Well, thank you so much for being here with us, Dr. Gerard Baltazar from NYU here in the NYU Winthrop Hospital in Mineola. And so this is Dr. Jeanine cook-Garard from the nursing department here at Nassau Community College, along with my student co-host, Virginia Gavin. And we want to thank you, the listening audience, for tuning in to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the Nursing Department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.
The views expressed on air are not necessarily those of WHPC.